My name is Vivian Sanan. I'm with the Survey Statistics and Psychometrics SSD Core Committee. And thank you all for joining us for today's presentation on context and change in health research using a multi-level model approach. And today's presenter is Dr. Julia McQuillan, who is currently on sabbatical and is kind enough to come and do this for us. So her sabbatical is equivalent of any normal person's normal job. So when she's normally in her job, really, then it's crazy. But she has been here for since 1998, 9 years. She came back from sociology, and you'll find out about it. It's easy to find out about it. I don't think we will put on my grade. The first, some of you were kind of being here just with her. You're welcome to leave it to do documentation if you have conflicts. Julie's presentation has changed a little bit. In the first session, the lecture is actually probably going to be about an hour and a half. So if you leave, she won't be offended, but otherwise, I'll just hand it over.
I'm going to be talking this way because everybody's sat over here, so you can stay there, but my back is a little hard for me to. Well, good afternoon. Welcome, and I'm so many of you here interested in context and change. I took that title actually from another paper that's in one of your handouts. I have a list of references. Something like a multi-level model approach to my kind of data because I'm at a crossroads of what to do. And then I'll talk about some of the kinds of questions that multi-level modeling can answer. And one of the things that's exciting for me as a sociologist is that I think before I knew about multilevel modeling, I was limited in my ability to look at questions of social structure at higher levels influencing lower levels. And learning about the technique actually changed the way I thought about questions. And when I listened to theories, I thought more about, well, how can I really get at modeling this theory instead of sort of being stuck with a not so good match to the theory. The theory was about how something at the structural level was influencing, let's say, individual behavior, but all I had was at the individual level, I never really was able to model how structure influenced individuals. Once I had the tools for that, I started to see a lot more research questions and possibilities. So we'll go through some of the research that's been done, and hopefully you'll think about how that might apply in your own work. And then I'm going to give you a substantive example, and then in the sort of second part, if you say, I've got some output, and we'll go through looking at statistical output and saying what coefficients answer what questions, how do I make sense of this output? Because the output, well, there's literally Greek letters in it, and it can be challenging for people. It took me years to really get comfortable with reading multilevel model output. It's one of those things where once you get it, it's like, oh, it's so obvious. But I never, in the olden days, they didn't have graduate seminars in multilevel modeling, so I had to figure it out myself and pester a lot of famous people with email and get them to help me. Okay. So how did I get involved in multilevel modeling? I was very fortunate as a graduate student. I was a sociology graduate student. I was hired by two researchers at the medical school who had been collecting a 10-year panel data. They had 988 people at the beginning, and they surveyed them every year for 10 years. Some of you who are methodologists will understand when I say one of the years, 9 of the years they had telephone surveys, 1 year they had a mail survey. The results were different in the mail survey year, significantly different. So we usually kind of analyze it as a 9-year panel study because the mail year gave us trouble. They sent me to a 2.5-day workshop on multilevel modeling so that I could help them analyze their data. I went to the Round Motion Break workshop and came back ready to analyze their data, and still have lots of questions after that. So my entry to multilevel modeling was looking at how do we model change, within-person change over time, to answer the research questions we wanted to answer. So some of the examples of questions that we explored. The first one we tackled was, does the general level and rate of change of fatigue over time? Fatigue is an important outcome for people with rheumatoid arthritis. This was a survey of a nationally representative sample of people with rheumatoid arthritis. Does it differ for those with and without a history of affective disorder? At the time, this was in the mid-90s, there was a lot of interest in what was called the SCAR hypothesis, that individuals who had an episode of major depression or generalized anxiety disorder, or both, that they met criteria for both, that left a scar on their body. It actually changed their physiology and could alter the way they experienced disease. And so we were trying to figure out, is altered by the positive events and negative events they experience at work, and if they had a more flexible work situation. So if they had high control over the work and either high demands or low demands at work, if that would influence their experience of daily positive and negative events. So there's a complicated question about the structure of work and about fluctuations day to day within people, and then also differences between people. So there's a really complicated question. So we used multilevel modeling to address those questions. The third project we're just finishing up, Dr. Fifield again did a study of, she wanted to know if guideline adherence medication, as prescribed by the board of physicians in the federal government, would improve asthma for low-income children. So she had 4 clinics of low-income youth that all had asthma. And they did an intervention on the physicians. They had a tool, a 1-page tool, on the front of the patient's chart. And the physician was supposed to answer the questions on the chart, and the answers to those questions about triggers, about number of episodes of asthma, about level of control of asthma, would lead to a decision about what the medication should be. the intervention actually had two parts, and in all of the clinics, they did this intervention where they got this guideline adherent medication sheet to help the physician to try to encourage them. In the absence of the guidelines, physicians were overprescribing fast-acting steroids, which led to long-term problems with asthma. So they wanted to get the physicians to do less of the fast-acting and more of the long-term treatments for child asthma. And they wanted to see if this could work in a low-resource environment in a clinic for high-poverty patients. All of the patients are either African-American or Hispanic. And if that intervention could actually improve the asthma control. So first was to see, can you get the physicians to do it? The second was to see, does it have an impact on asthma control? The other thing that was part of the study was, in addition to all of the physicians having the new sheet, they also, for two of the clinics, the physicians got feedback the next day, electronic feedback that said, you either did prescribe a guideline adherent medication or you didn't prescribe guideline adherent medication. So the question there was, can you improve, can you change physician behavior? Can you improve asthma control? And did the second intervention work even more? Do you need the feedback to the physician, or is just having the insert enough? So that's an example. There was a recent article in 2004, it's by O'Connell and, it's on your list, of introducing multi-level modeling for intervention researchers as a tool for evaluating intervention. And a common theme in the last 2 years in multi-level modeling books and articles is, don't be afraid, it's not as bad as you think, it looks really complicated with all these equations, but you can do it. It's just regression. I kind of think of it as regression on steroids. But it is just regression. And you know what? That's my theme too. Like, it looks really complicated at first, but you can do it. If you have the kind of questions that'll be useful for, that really makes life easier in the long run. It just takes a little bit of investment up front. So part of my goal today is to give you this overview to help you decide, do I need this tool? And maybe in the back of your mind, if you don't need it today, down the road as you approach different research questions, or you collaborate, or you work on projects, you might go, hey, you know, this sounds a lot like that multi-level model thing. Maybe I'll look that up again. Okay. Multi-level modeling. Oh, the other thing is context. So in the title, I sold this as looking at change and context. If you talk to people who've been doing multi-level modeling for a while, or if you talk to people who develop it, who write software or write books about it, it can do anything and everything better than anything else. So I'm not going to necessarily say that that's true. But there are some compelling arguments why, for longitudinal data, it's a very useful tool. It's also a very useful tool for other kinds of nested data. So we think of longitudinal data as observations nested within people. We can also think of people nested within institutions. For example, students within classrooms or students within schools. We can look at community members within communities. We could look at individuals within states, individuals within countries. We can think of a lot of types of nesting. And we can think of the higher level as a context influencing a lower level, what's happening below. You can actually also think about this. I don't have an example up here, but Edith DeLiu has several articles on this. You can think of items on a survey as nested within the person taking the survey. And you could look at different kinds of survey items that the person is the ordering in the survey could be the context for how individuals take a survey. So, are there any SRAM students in here? Survey research and methodology? No. Okay. Well, that would be a plug for the SRAM students. It's becoming very popular for doing a survey context, ordering effects, and issues in how you construct a survey and analyzing the usefulness of the survey. So I got involved with looking at context questions. I don't know why it's right here. Oh, not the video. I got interested in context questions, collaborating with Dr. Stone, who recently left UNL to go to Massachusetts to be near her family. She was interested in labor market effects on wages and the relationship between Hispanic subgroup membership and wages. And so we did she took census data, and we looked at individuals within labor markets and analyzed the labor market context and how that modified, did or didn't modify the relationship between Hispanic subgroup membership, Puerto Rican, Mexican, or Cuban, and wage differentials. One of the questions in research on labor markets is if there are enclaves of workers. For example, Cuban workers in Miami might actually be doing great because they have the networks, the community, they've got more higher educated immigrants. Might be very different. And if you're a Mexican immigrant in Rhode Island, it might be different than being a Mexican immigrant in New Mexico. And so we were trying to figure out, and also we were trying to look at and see if there was just a discrimination effect. You know, if you have different skin color, are you going to be discriminated against? Or did it matter the particular subgroup? And if the labor market effects affected all three groups similarly, or if there were variation. So that was my first context paper, and then just finishing a paper with a collaborator, hopefully finishing it today. We've been working on it very hard, looking at if occupation as a higher level context, the occupation characteristics influence risk of injury for workers in the workplace through self-reported injuries. So there's a lot of work in public health on individual characteristics that could influence workplace injuries. Age, education, gender, training, length of time working in a job or an occupation. There's been less work, although some, on how dangerous an occupation is. We know that trucking, health, mining, those are all more dangerous occupations. What's been less studied, and from a sociological perspective is very interesting, is if the occupational racial structure could also influence risk of injury. And if it could differentially influence risk of injury for individual race or gender. So you can have, the occupation can have a racial structure, the percent black in that occupation. So you could look at race as a characteristic of the occupation. More racialized occupations, can they differentially influence the odds of injury, and if the individual person's race, gender modifies that association. So those are some context questions, and we're going to be looking at some examples that relate to health. So many major health improvements have come in the form of social structure or context. Simply improving clean water can have a huge impact. Creating clean water can have a huge impact on health, morbidity, and mortality in a nation or in a community. That's a context effect. It's not dependent on anything about individuals. It's a higher level structural effect. So we can think of other kinds of questions. Some of you may be aware of research that's going on looking at the odds of having a heart surgery based on how many heart surgeons there are in your community, or the odds of having different kinds of screenings. If your hospital all of a sudden gets an MRI machine, maybe a lot more people are getting MRIs than they did before, and you might have a sudden jump in certain kinds of illnesses because now they can detect them, whereas before they couldn't detect them. Well, that would be a context effect, something that happened at the higher level that would influence a lot of units within. So we can also think of physician effects. We might look at patients within physicians, patients within hospitals. Anytime we have nesting, and there's a lot of nesting in health research, very similar to education research, multi-level models will be useful. And also, as the example I gave before about the child asthma, there's possibilities for analyzing the effects of interventions, especially if you have interventions that are at a site level. So instead of taking a school and giving half of the students one curriculum and half of the students another curriculum, if you alter the curriculum by school, then you could think of students nested within schools and look at the student level analysis and the school level analysis. Okay, here's a couple examples recent examples from health research. I think that R shouldn't be there. It should be Kawachi. It shouldn't be Kawachi. He's one of my favorite researchers. I can't believe I spelled his name wrong. And he's done a tremendous amount of work on socioeconomic status and health. And he extended his individual socioeconomic status and health research to look at community socioeconomic status. And also, he's been looking at social capital, the bowling alone idea, and looking at how social capital influences health. And he shifted again from individual social capital and individual socioeconomic status to see, does it matter the community level social capital and the community level socioeconomic status? So even if an individual might have low socioeconomic status, low income, low education, if their community has high resources, they might get a health benefit from just living in a community that has a lot of healthy resources. Safe, clean places to walk, available good food, good health care. They could get a bump from living in a better community. By the same token, higher income folks living in a low resource community, a low social capital community, might experience a deficit. There's also issues of trust in a community. If you live in a community that has more trust, more ties between people, you could get a health benefit from that. Even if your own individual social capital is low, you might not have a lot of friends or a lot of people you socialize with, but you could benefit from the overall community effect. So what they did is they looked at states as the community, which is, and this they don't even address, it's a very short article, it's one of these really short medical articles, but as the higher level, would be better if they looked at more immediate neighborhoods or community effects. But they looked at states, and they got indices from about 10 different sources of the state level social capital and state level socioeconomic status. And then they had individual data from the health risk behavior HBRS surveillance data, and they analyzed if there was a context effect. You want to know what they found? They found some, I can't do all the results, but they did find some small amount of community effect, but most of it was at the individual level. Now, here's something that I've been finding recently is that happens more often than we might think, because there are a lot of questions about context. So at least I as a sociologist, there should be a context effect. They didn't find a huge one, and a lot of studies don't find a huge one. I think part of it here is, again, the lack of precision by having a state level as a level 2. I think most people are more influenced by their, like if you think of California as a state, it might be very different being in Oakland than in Berkeley, being in San Diego than in even Los Angeles. So there could be some, they might have a better analysis, probably if they use the labor market like I did. It might be. Okay. And they also, you only have 50 units if you have states. And I should be at 48 because I don't think they did Alaska and Hawaii. Does anybody have a question? I'm just kind of going through this fairly quickly. Are you doing okay? Are you with me? You're hanging there? Okay. All right, so why people use multi-level models? I honestly can't remember if I took this from something I read, like Rodenbush and Brick, which is one of the classic textbooks. I'm pretty sure I did. I don't think I thought of it on my own. But it's a common way to think about it. When I talk to people who use multi-level models, most of them either came to it because they had a data set that confused the hell out of them. They couldn't figure out how to analyze it, or they had questions. They were taking their contextual or their longitudinal. They had questions about change over time, or they had questions about context, and they wanted to figure out a way to answer those questions, and they couldn't do it with ordinary least squares regression or ANOVA or some of the tools that they had. And so I'm going to talk about both entrees into multi-level models. In the second part, I'm going to give you output, and we're going to go through and say, how do we read this output to answer these questions? Just a little heads up, many of you may already know multi-level modeling just by another name. They're sometimes called mixed models, mixed effects, random coefficient, and I have a little handout in here on this. Just find it. Covariance components, random coefficient models. They have a lot of different names. Oh, and the longitudinal is also called growth curves. Have you heard of growth curves before? That's a terrible name. And even the people that use it think it's a terrible name because it implies that you're going to have an increase. And you can just as easily have a decrease, or you can have curvature. You can have a lot of other, it's because it came out of educational psychology looking at verbal ability, children acquiring words, and looking at, it came out of a discipline-specific topics. And so it can also be, it can be confusing sometimes when you're looking at like a disease trajectory. We don't really want it to grow. We really want like an increase. So I tend to prefer language like longitudinal, studies of change, but growth curve is pretty common. Okay. I like multi-level model because it's pretty general. I tend to slip into HLM often because HLM is a software-specific term. Hierarchical linear models is it can be a general term, but it's also the name of a particular software. And I'm not interested in promoting any particular software, so I'm trying to use the generic multi-level model. Okay, so you can interrupt me if you have a question. This is a conceptual introduction. I am going to be doing a little bit of equations, but not a lot. This is really not going to be getting into maximum likelihood or covariance structures or matrix algebra or any of that. This is really just the basic underlying conceptual logic, and then I would say that. Okay, this is my little plug for You Can Do It. You can learn ordinary least squares regression. You can do multi-level models, and the fact that I'm standing up here means you can do it, because I can figure this out. Almost anybody could. I stopped learning math in high school, algebra 2, and had to teach myself calculus to understand this, just a little bit of calculus. So if I can do this, anybody can. You have to want it. So if you have a question, a burning desire to figure something out, it's totally doable. And it's so much easier now than it was 10 years ago. They have some great books. I have some with me that I can show you later, but they have some great introductory books. Yes? Ordinary least squares regression. That's your standard multiple regression. And that's a really good question that I take for granted now. Before I learned multi-level modeling, it was just regression. And then I realized that they were the generalized linear model and the broader way of thinking about statistics, that really I was doing a specific form of regression, ordinary least squares regression. There's maximum likelihood, there's other forms of regression. So that's what it's. So now I have to say OLS regression because I know there's different kinds. You can do multi-level modeling with a lot of software. And on a daily basis, I forget you can do it with SPSS. And because for so long, you couldn't. But in the more recent versions, you can. They have a new mixed program. Now, I say you can because I haven't taken the time to figure it out. I will take the time to figure out new software when I need to, but I don't do it just for fun. Some people do, but I don't. And so I've gone to 2 workshops and there was one here last year. Did we have Dave Kenny last fall? Did we what? Dave Kenny. Did he come last fall? Must have been 2 years ago. Is that long ago? Yeah, it must have been 2 years ago. Dave Kenny came and did a great workshop using multi-level modeling for looking at couples, looking at both partners in a couple as nested within the relationship. And he then extended that to over time. And he was a really neat project comparing same-sex and opposite-sex couples and trying to get at issues around gender by looking at gender of the individual and gender of the couple, and mixed gender or same gender. And I forget what the outcome was. I was just so taken with the analysis. And he did a workshop on using SPSS to do multi-level modeling. You can use M+, Stata, SAS. SAS is great for mixed models. And we have here at UNL Walt Stroop in the statistics department, who's one of the co-authors of the manual for mixed models. He did a wonderful workshop for us in the spring, which we have on the web. Us is the SSP, Survey Research Statistics and Psychometrics. That's the first web page on your handout. And, so if you like SAS and you want to know how to make SAS do mixed models, Walt gave an all-day workshop on how to do that. Handouts and the video, no, not the video, but the handouts right there. And he's here on campus, and he's just a phenomenal resource for doing mixed models. Some are more flexible than others. I have SAS envy, and so I wish I could get my brain around the work log thing. That data step, just cannot do it. And someday, I've been told there's a little book that I can get that will help me figure that out. I'm going to try someday. The beautiful thing about SAS for multi-level modeling is it's very simple to do error structures, especially for longitudinal data. It's much more complicated to do error structures with the HLM software that I use out of habit. The hard thing about SAS models is that it's very easy to set the model up wrong and not know it. And so usually what I do is I find somebody who knows SAS and I have them check my models in HLM, make sure I get the same results, and if I have a complex error structure, I just have them do it for me. So to make sure that I don't, actually to check it to make sure I don't, because usually I don't. Any questions about the data software? Great, so kinds of data. So I already talked about several of these different kinds of data. One that I haven't talked about is meta-analysis. So some of you may be interested in meta-analyses where you combine results from multiple studies. And multi-level models are great for doing that. There's a whole chapter on it on almost all the major books on multi-level models. It's not something I've done, but it's very doable, and it's supposed to be much more flexible than other approaches to meta-analysis. Once you start to think about nested data, you see it everywhere. And hopefully you'll have a shift in thinking. It's literally like another dimension, second level. And really excited about the possibilities for research. This is from Craig Duncan, Jones, and Moon. This is, I stole my title from their title on context and change in health research. These are some examples of data structures, and I'm afraid it's a little bit small. But what this is showing is here's a two-level structure where you have people within places. So there's 3 people in that place, 2 people in that place, and 2 people in that place. One of the things we'll learn about multi-level models that's great is that you don't have to have the same number of units within each higher level. So in repeated measures ANOVA, one of the assumptions is that you're going to have the same number of observations for every person in the study, if you have observations of people. You could also have, I have a student who did his dissertation looking at 20 years of data on 140 countries. So he was looking at the within-country data and comparing within and between countries. So one of the restrictions of some other approaches to longitudinal data is that you should have the same number of time points and they should be equally spaced. With multi-level models, they don't have to be equally spaced and you don't have to have the same number of observations for each higher level unit. So one way to think about nesting, and it's actually something I forgot, but it can be very confusing first thinking about multi-levels. Like, what is my level 1 and what is my level 2? What is nested within what? And if any of you know Microsoft Access database manager type things, if you ever have many to one, the many is going to be your level 1 or your lower level, and the 1 is going to be your higher level unit. We'll practice that with lots of examples. You can have more than 2 levels. So here we have people within places. You could also have people within neighborhoods and neighborhoods within states. You could have multiple observations on students. So the observations would be level 1, students would be level 2, and the students could be nested within either classrooms or schools. So you can have 3 levels. Do you have a question? You can have more than 3 levels. It hurts my brain to think about it. When we start looking at some output, you'll understand why I say that. Not all software will do more than 3 levels. And the data precision and other issues get pretty funky when you get more than 3. And there actually aren't that many 3-level analyses. I haven't published any. I've done some for people. We've actually usually ended up deciding to do a 2-level and using the 3-level as fixed effects. We just have dummy variables for the 3rd level. One of my colleagues, 2 of my colleagues, I've got 9 new colleagues in the last 2 years, have done 3-level analyses, and I'm pretty sure Walt has too. So that's a possibility to think about. Here's another 3-level, people within time within place. So before the time was at level 1, multiple observations, you can also have multiple people in a year, like 1992, 1993, and years nested within places. If you want to look at change over time, let's say, of a community. There's some other multi-level data structures. I've already talked about time within people. You could also have multiple responses. Portions within people within places. This would be like item 1, 2, and 3 on a survey, and having those within people, and then within places. And this is cross-classified models, which I have not done yet. Lisa Hoffman in the psychology department is, I consider, an expert on cross-classified models. And that's when you have 2 different level, and you have 2 different level 2s. Here it's workplace and neighborhood. And so a person might be classified in this neighborhood, but in a different workplace. So they're not necessarily in the same neighborhood. The workplace might not be in the same neighborhood as the person lives in. So you could actually have 2 level 2 units that they're nested within, both the neighborhood and the workplace, the same person.
So you can do and that is useful if you're doing research on education. If you have a group of students in kindergarten, and then in first grade, some of them go to one teacher and some of them go to another teacher, you would need a cross-classified model to see what's happening with them over time. Yes?
Is this concept similar to the factors or dimensions or not?
I don't think of it that way. You're thinking of latent variables in terms of...
Yes, if I have, because you said that probably it could be people and they
So actually, this is hard to see, but this is level 2 and this is level 2, and this is a person, and so this does sort of look like a latent variable model, like a structural equation. I didn't even think about that. It does look like a latent variable structural equation model. That's not what this is. This is a data structure, and it's saying that this person is in this neighborhood and in this occupation. This person is in this neighborhood and over here in this occupation. So some people, their workplace is in their neighborhood. Some people, their workplace is not in their neighborhood. Okay, that's a good question because it does look like a latent variable model. Okay, so because I didn't have any context examples for health research, and I wanted to focus this on health research, I made one up. So I made up a question, I made up data, and I did analysis on it. So do not, report this. And, I have 6 cases, so if you did well, you're not thinking too hard about data. So I just oversimplified, and if any of you know physicians, tell me if this is offensive. Because I was trying to think of something that was innocuous, but interesting. So I wanted to pretend that I randomly sampled physicians. So physician is going to be my level 2, my higher level. And within physicians, I randomly sampled their patients. And somehow I was able to measure how long they spent with each patient, how many minutes they spent with each patient. I also got information on how long that patient had been in that physician's patient. And I'm interested in why do some doctors spend more time with their patients than other doctors? And my idea is that family physicians who are trained in a more holistic approach to healthcare might spend more time with their patients than non-family physicians, sort of internists or more, what's a non-family physician? Just a physician. Family doctors usually have a broader practice, so specialists, like an OBGYN. Because a family physician should ask about more areas of your life and do a more holistic approach. So that was my idea. Now you might stay for a minute and think, well, why else might some patients or doctors spend more time with their patients than others? It could be because the doctor maybe has an older patient group and they need to spend more time, maybe it takes longer to go through the medical history, they might have to spend more time listening and talking. It might be because they have a sicker patient mix. So it could be that they're taking longer because they have more to cover. It could be that some of them are quicker because they have a heavier volume of patients, so they have less time for patients, so their overall practice might be busier. We could think of a lot of reasons why. Maybe if we had some measure of empathy, that some doctors who are more empathetic might listen more. They might listen less because it's more painful. I don't know, bother them more and their patients having a hard time. So we can think of a lot of reasons why some physicians. Now, we could also imagine, now that I'm telling you this, some nefarious use of this kind of data, like in terms of if I was an insurance company executive, I might not want my doctor to be spending a lot of time with patients. On the other hand, if you wanted to rate your doctor, it might, to have a doctor that spends a little more time with you might be a useful thing to think about. So, does this make sense? Okay. Okay. So this, I just told you this. So here's one way, another picture of data. Here's 3 physicians. The first physician has, that's supposed to be 6 patients, and it's only 5. I think I lost one in editing. It's supposed to, there's that patient. So it's supposed to be 3 and there's 4, so somehow one slipped from that doctor to this doctor. 2, good, 2. So what I want you to get, the idea is that we have the patient level and the physician level, and patients are nested within physicians.
So here's an example of a traditional flat file. And here's another piece of terminology that I didn't know because I didn't need to know because this was just the only kind of data set I knew. This is a data set where every time you have a new variable, a new piece of information, you have a new variable. So this is a physician data set. So let's just say I have 6 physicians. So what happens when a physician gets another patient, and I'm measuring the time with the patient and how long the patient's been with the practice, I need patient-specific information. I need a new variable. So I've got number of years in the practice for patient 1, number of years in the practice for patient 2, patient 3, patient 4, patient 5. And then I have to start over for the number of minutes the doctor spent with that patient. So this is the first patient for Doctor 1, the first patient for Doctor 2, or physician 2. Does anybody know the politics of that? Is doctor or physician one of those better than the other? I have no idea. Okay. For some reason, a physician, I always like physician better because I'm a doctor. And I'm not going near anybody's blood. I'm a PhD in sociology, so I like physician a little bit better. And you'll see that there's some missing data points, and that's because here we only got data on 2 patients for that doctor. Either we tried to sample 6 and we didn't get them, or we only were able to find 2, or we only wanted 2, but we have a lot of missing data, but we don't have the same number of patients for each physician. And what happens when we have another patient come along? We need to create more variables. This is more common probably in longitudinal data, where let's say we get funding to collect data for 2 waves, and then we are so fortunate and we submit a continuation, and we get 5 more years, and so we collect more data. So what do? We keep adding variables on, so we have the wave 1 data, and we probably don't even call it wave 1, right? We don't label every variable with a 1 because it's just the data. But then on the same people, we collect data again, same questions. So now we have the same variables, but now we add 2, so we know it's the second time we surveyed them. But we have this, each row is a person, so we're adding variables to that data set. Then we get the funding, and we get 2 more years. We're all supposed to smile. It's a very happy thing. So, hey, we got the funding. So then we have to add another block, and these are the 3 variables. And then, we get 4 variables. And then Mindy worked on a project, 20 years, 20 years of funding. Every 5 years they got more funding. So they kept adding on. They were not kind. They changed the whole variable name every data set. They didn't just add a 2 or a 3 or a 4. They changed the whole. I worked with that data. Anyways, so this is a flat file. So this is your standard. So this is a physician level flat file. What are we going to do with this? How are we going to answer our question? It's really challenging because how do we average across the years, the average number of years or the average number of minutes for that physician? It's really hard to work with a flat file when you have repeated observations within. There's a trick. You restructure the data. We stack it. In the olden days, this was a nightmare. I'm talking the 90s. If you use SPSS, if you use SAS, everything was wonderful because you were a SAS stud and you could restructure your data. But if you use SPSS, it wasn't wonderful. It was a nightmare. You had to do these workarounds. But now they have these nice little commands in SPSS where you just restructure your data. You say, take all those different variables for the patients and switch it so that instead of having a row of data for each physician, now I'm going to have a row of data for each person, for each patient. And the physician information is going to be repeated. So the family doctor, every time it's going to be the same for that doctor. Doctor 1 has 3 patients, and the first patient had 12 years in the practice and 20-minute visit with the doctor. The second patient had 11 years with the practice and a 15-minute visit. And this is a non-family doctor physician. So this is the exact same data, except for I had to cut off the 6th doctor because I ran out of space. It's the same data on your previous slide in that flat file, where each row is for a physician. Now I've taken my within units and I've made each one a row. So for longitudinal data, what I would do is if I had observations within people, I'd have a row of data for every observation. And the ID number for the person would tell me, okay, it's person 1, observation 1, person 1, observation 2, person 1, observation 3. So now I could take this data set and I could do a regression where I could look at number of minutes by type of physician. I could have number of minutes as the outcome and type of physician as the predictor, if it's a dummy variable for family practice or not. And I could see if that, in fact, is associated with how long the physician spends with the patient. I could also add a variable for the the patient-specific data on if you've been with the doctor longer, do you get shorter visits with the doctor because he already or she already knows you? Or do you get longer visits because they like you and they're, how the kids and everything, how's the business and whatever. And so, or maybe there's no association. So now it's much easier to deal with by repeated observation data because I've stacked it. But I still might have questions about the physician level analysis because now I've gone to a patient. And I also have another problem. I'm violating an assumption of multiple regression. Anybody remember there are, depending on the book, 4 or 6 assumptions of the error term for multiple ordinary least squares regression? Normal, homogeneity, variance. I'm violating the assumption of independence because I have multiple observations. So some of you go, I knew that, but I mispredicted my thing. So you violate the assumption of independence. So I can go ahead and ignore that, and people do it all the time. But you're going to get away with it less and less often because reviewers are getting pretty savvy that you need to take care of that. You need to at least find out if there's a clustering effect. If patients within a doctor are more similar to each other than patients and within doctors than they are between. Now this could also be a nuisance that you can take care of with a correction for that lack of independence. In Stata, I know how to do it. You just do a little cluster correction. And you just say, adjust the standard errors, which is the focus of a lot of this analysis is the standard errors, is trying to figure out to get the appropriate standard errors. And do we remember why standard errors are so important? It's because the coefficient divided by the standard error gives us t. And t is what we use to determine if that coefficient is statistically significant. If you have a normal distribution, t that's greater than 1.96 is going to be statistically significant. It's going to happen less than 5 times out of 100 by chance alone. So it's going to say, wow, that's really rare. I bet there's really an association because that wouldn't happen by chance alone, probably. That's our basic hypothesis testing logic. So standard errors are really important. Now, I never really knew how important standard errors were until I got to this world. And then you hang out with statisticians and it's all about the standard errors. Pretty much. We want that unbiased estimate, but we also want to make sure that our standard error is right. And it should be really important. Because a lot of decisions are made on p-values, on the probability that that would happen by chance alone or not. So we could take care of that with the cluster command and say, we've taken care of it, now we're going to analyze it. But don't you want to know if there's differences between physicians? I mean, I don't want to just take care of it. I want to model it. I want to understand it. I want to find out how much of the variance is within physicians and how much is between. And why? Why some physicians have more time than others. So for some of you, and some papers in my own research, I might say, I just want to take care of that clustering, and I want to just do I'm interested in my coefficients for my main variables. Fine. You do a cluster command or Stata, you do some kind of statistical Huber-White tailorization of the clustering, you take care of that, and you've got your standard errors corrected. But if you want to know how much variance is within and between, and you want to know why, and you want to model it, then multilevel models are a really good way to go. Any questions on that? I just briefly, when I was at this workshop with Brad Bush and Britt, they kept talking about 1.96, T 1.96. And I was in graduate school, and we didn't do T 1.96, we did P.05, less than P.05. We had to talk about T 1.96. I was like, why are they so obsessed with this number? Like, what is this number? What is this 1.96 that they're so excited about? I was baffled until I started teaching here, and I was like, oh my God, that's the 1.96. That's the standard normal distribution. Okay, so it's very exciting to get the z-score, 1.96. So we can take that stacked file, and again, very easily in SPSS or other software, we can aggregate it up. Or we could say, go back up to the physician level, but now it's easier to use. Now that first step, that flat file might not be an issue for some of you. Some of you, your data might come to you as a stacked file, or it might come to you as an aggregate file. And that step was only for people who get the data in that form. That can be one of the biggest blocks to analyzing your data, is getting the data in a flat file form and having repeated observations be new variables. Because you just kind of look at it and go, what the hell am I doing with this? So stacking it helps. And then here what we've done is come back up to the 6 physicians. And now we have the mean minutes that physicians spent with all the patients in their that we've studied, and the mean number of years. So this is a much more experienced physician. This is a physician that has newer patients. I shouldn't say experienced. This is a physician with patients that have been with them a long time. This is a physician, and maybe one of the other variables it might add is how old the physician is. Maybe older physicians might spend more time than younger physicians. This is the number of patients within the physician. So that might also be useful information. So we've taken a flat file, turned it into a stack file, we'll take the stack file and aggregated it up. So we can use this information. Now we could just analyze this, right? We could say, well, we have the average amount of time the physician spends with the patient, the average length of time patients are in the practice. So let's just analyze the physician data, and we can get our answer to if family doctors spend more time with their patients than non-family doctors, right? That's a good solution. We have pretty reliable estimates of the physician level. We have more reliable estimates the more patients we have, right? That's basic statistics. More observations you should have, especially if they're randomly sampled, you should have better, more precise information. So the physician that has 5 patients, we can be more sure of their averages than a physician with only 2 patients. The problem with doing this kind of analysis is that, well, but we don't know if that mean has a narrow confidence interval around it, a narrow band, that's really their true tendency, or if there's a lot of variation around it. So we could, we might want to know that these 2 physicians that both spend about 7 minutes on average with their patients, this might be 7 minutes with a range of 5 to 30, and this might be 7 minutes with a range of 6 to 8. So this physician is much more consistent in how much time they spend with their patients. This one has a much wider variance. Remember what the variance is? We take the mean, each value minus the mean squared divided by n, so it's the spread, the average spread in square digits. So what if we want to know, well, gee, now I know between physicians, but I don't know within that physician why the physician spends more time with some patients than others. I can't answer that question about if it matters if the patient's been with the practice longer, right? So what do I do? Am I going to do it within the physician, or am I going to do it between the physician? This is a terrible choice. I don't want to choose. I want it all. Do you want it all? Let's have it all. We live in a great age. We can have it all. You know why? Multi-level moms. This is why I'm so excited about them. We can have it all. So we can run the regression with minutes as an outcome, and let's see, what if we did the stacked file? We have a larger sample, but we violate independence. What if we do the physician, more reliable measures? We don't violate the independence, but we don't know within. What are we going to do? Multi-level models. So what is the multi-level model going to do for us? Briefly, and I'll go through this a little bit in more detail. it's going to basically run a regression, a multiple ordinary least squares regression. It's just conceptual. It doesn't actually do this. For each physician separately. It'll get an intercept, and it'll get slopes. So in this case, you would have 6 intercepts and 6 slopes. And then we can use those intercepts and slopes. This is really funny. What's that? Oh, that's my phone. Oh, it's another funny light. Sorry, I have a child in school and a sick husband, so I have to leave my phone on. So, where are we? I can run a separate regression 6 times for each physician, and then I can take my 6 intercepts. I'm looking at you realizing it would be really useful if I could draw the regression equation. Okay, write this down. Y equals, you don't have to write it down, but if you know it by heart, but since I didn't write it down, you can write it down. Y equals A plus BX plus R. That's our dear friend, the regression equation. Wonderfully useful tool. The linear regression equation. So A is the intercept. Now if you haven't done this recently, and if you haven't taught statistics every year for the last 10 years, this might not be part of your everyday thinking, but A, the intercept, is the average of the dependent variable. So in this case, it would be the average minutes the physician spends with the patient when all the other variables have a value of 0. So when x equals 0, all the x's equal 0. That's my intercept. And then B is my slope. Now I do actually have this on a later slide, but so B is my slope. It's the relationship between the independent variable and the dependent variable. And so I'm going to have 6 intercepts and 6 slopes. And I can actually use those as new variables in my physician data set. So at the physician level, I can add those 6 intercepts. So for each physician, they're going to have an intercept and a slope for that within-physician relationship between, let's say that X is length of time in the practice and length of time in the visit. And then I can actually have predictors of why some physicians spend more time than others. And actually, I can also see if that slope varies by physician characteristics. And so the multi-level modeling approach is going to do that for us, but it's going to use a maximum likelihood estimation procedure to do that. It's called the EM algorithm. And it'll give me both information, and then it'll also tell me how do different physicians vary around an overall average and an overall slope. Yes?
Normally, if you're going to fit a regression, you like to have a minimum of 10 data points or something like that. And many times in these models, they may just have 3 observations.
I can have 1.
Or 1.
And 2. Yep.
You have to have 2 to fit a slope. And so, do you
How
get
does
a hard
that
time from reviewers when you do that sort of
No,
thing?
because...
Or they just overlook that?
No, what happens is if you don't have... the general recommendation by Jupox is a minimum of 25. He's done some Monte Carlo simulations. You want a minimum of 25 observations. Everybody knows that usually with longitudinal data, you're not going to have that. So here's the magic way to get around it. It's pooling all that information. It doesn't really run a separate regression for each case. It does this maximum likelihood estimation, and it pulls information, all the information it has. So it gets an overall average, as if we had analyzed the data as just a stacked file. And then it takes the person-specific information, in this case the physician-specific. So you only have 1 or 2 or 3 observations or 5 within a physician, but you're borrowing all this information from other units in your data set. The example that they give in the Raudenbush and Brick book is research on minority applicants to business schools and trying to figure out if there was discrimination. There were so few minority applicants that it was really hard to analyze. But if you aggregate the data across all the business schools in the country, you could borrow that information, because what you're going after are the estimates of the coefficients and the standard errors. So the more observations you have, the more patients within physician, the more precise, the more reliable your estimates are. But and you might have some outliers by having only a few cases. there's this beautiful thing called shrunken estimators that are corrected for how unusual the case is. The further out a case is from the overall average, the less weight it carries. So it's a way to, actually a way to take advantage of as much information as available, kind of overcome that disadvantage of having only a few. So, but I haven't, but I've been pretty upfront. I've used fixed effects pull time series when I've only had 2 waves within a person. I sold it, so you can sell it. That's another thing you can talk to people at the SSP about, framing the limitations of your data together. And then there's some reviewers you can't get around. So, here's what I just told you to write down. I need to put that slide a little earlier. And here's writing it 6 times. Now, there's 4 things that could happen if we do this 6 equation approach. It could be that every physician has the same intercept and every physician has the same slope, that there's no difference, that there's a lot of consistency in how much time physicians spend with their patients and the relationship between length of time in the practice and time with the physician. So that would be that there's no physician effect. There's just, this is what happens. The physician doesn't matter. Has constant intercepts and constant slopes. We could have that all physicians tend to spend the same amount of time on average with their patients, so it would be the same intercept, but they vary in their, they could spend different times with their patients with varying intercepts, but their slopes are the same. If the longer a patient's been in the practice, the shorter their visit. It could be that they all have the same amount of average time, but the relationship is different. The slopes vary. And it could be that both the intercepts and the slopes are different. And I'm going to show you a picture of that. This is from Hoffman, 1997. So we could find that we go through all this trouble to organize our data, to get fancy software, to set up an equation, to take care of the fact that we have patients nested within physicians, and then we can find that it doesn't matter, that there's just one intercept and one slope. The physician doesn't matter. It's just the patients that matter. Unlikely, but possible. It could be that the average length of time the physician spends with the patient, those different intercepts, so some physicians spend more time than others, but the independent variable to the dependent variable relationship, the slope, is the same for everybody. It could be that the slopes are different, but the intercepts are the same. And it could be that both vary. That you could have no relationship for some physicians, a positive relationship for some, a negative for some, and that they all have different starting points. And you don't know that unless you do a multi-level analysis, where you do both with an individual. Then the question is why? Why different intercepts and why different slopes? And we can model that too with the level, we'll call them level 2 equations or physician equations. So we can have a model for the amount of time spent with the patient. We could use patient characteristics for that. And we can look at how it varies within a physician. Maybe physicians spend more time with same gender, opposite gender patients. They might spend more time with older or younger patients, with patients with kids or not, with chronic illness versus acute illness, a variety of things, routine checkup versus an emergency visit. Those will be all patient specific. And then we can have explanations that have to do with the physician. If it's just older or younger, the kind of training that they had, their gender, their race, their patient caseload. So we can look at both the individual within physician patient level and the physician level. So take home message regarding your data. If you can't decide what level you should analyze it at, don't. Do both. Okay. So, any questions on that? Kinds of questions. How are we doing? This is basically, I've taken articles that have to do with multi-level model approaches to health questions, and I'm just summarizing them here. And my hope is that by doing this, you'll say, hey, I have a question like that. And it'll trigger something in you that says, I could answer that question using this approach. Okay, I couldn't think of any other way to get at the kinds of questions. When I teach this at the graduate seminar, you realize I'm giving you like 5 weeks in, an hour and a half of my graduate seminar. I have the students practice coming up with multi-level model questions. What kinds of questions could you answer? Thinking about their dissertations or their data or the things that they're working on. And one student, she came up with, so I thought this was very creative, and she hasn't published it yet, so don't steal it, but she's close. So she's way ahead of you. So if you even think about it now, she's got you. So don't. She has the National Crime Victimization Survey, I think, or Violence Against Women, and she's looking at multiple stalking incidents within a woman and seeing if the stalker characteristics or the person characteristics matter more for how afraid the woman is from the stalking. Because it would be really interesting to show that different stalkers induce different amounts of fear. Especially for the legal system to say it's not just that the woman is a crying wolf, or it's something about that woman that's making this stalking happen. Some of these incidents are worse than others. And it's a very interesting question. And also if it's the same gender or opposite gender stalking incident within the same person. Because one of the major issues in stalking legislation is that stalking is stalking if it induces fear. And men are less likely to be afraid to report being afraid of stalking, but it can't count as stalking unless they're afraid. So if men won't say they're afraid, even if they are, it skews the data. So this question of, within person is really interesting. So she has both women and men victims being stalked by both women and men. So she doesn't have a lot of incidents of multiple stalking, but she's able to use multi-level model analysis to get what she can from the data and look at the variance within and between. So here's some examples. Is neighborhood disadvantage a context measure associated with adult depressive symptoms controlling for individual characteristics? Catherine Ross did this. And she measured a slew of characteristics about neighborhoods. Broken glass and graffiti, crime rates, a whole bunch of information. She actually found that she did the multi-level model analysis, and she found that there wasn't a neighborhood effect. She could have just done all the analysis at the individual level. But she didn't know until she did the analysis. Does individual education level protect against daily stressors, physical symptoms of psychological distress? And is the stressor to health association weaker for those with more resources? This is Griswold et al. They used another daily diary study. This is just a few years ago. Are mental health symptoms higher over the life course among those whose parents divorced compared to those whose parents were continuously married? This was a 30-year study by Cherlin. Or he analyzed it, he didn't collect the data, it's British data, looking at the kids whose parents divorced, kids whose parents did divorce over 30 years, and we looked at their trajectories. This is a very recent article on stigmatization from receiving mental health care, and they were interested in if the kind of clinic the person goes to for health matters for the amount of stigmatization they experience, or is it only individual level characteristics. Health-related quality of life. And we were talking about this one, is it higher in states with more social capital? And then there's a really interesting intervention study that looked at HIV/AIDS education for people with HIV/AIDS and their condom use and looking at confidence using condoms. And they wanted to know, they had people who wanted to come to the intervention. It was a training. It was either 8 weeks or once a week, all weekend, or they couldn't come at those times, so they got on a waiting list. So they had a comparison group that wanted to be part of it but couldn't be. So they had 3 groups, and they assessed, did the intervention increase confidence in condom use, and if it mattered if you got the weekend or if you got the 8 week. So it's a really nice study. And then this is a German study that looks at cardiovascular risk and if it depends upon the wealth of the region that you live in. Or is it individual characteristics that matter more, or is it region characteristics that matter more? Another depressive symptoms and delinquency outcome. This is a recent study by Wright, Botticello, and Anna Schenzel looking at socioeconomic context and individual socioeconomic status. So all of these studies were 2-level studies looking at people in regions or people in communities or observations within people. They all used a multi-level model analysis, and so you might think about your own data and how it might have a multi-level structure, or your questions might be multi-level. If you don't have data yet, and you have a research question, and you're thinking about collecting data, power analyses for multi-level models are very complicated. You have a trade-off, assuming you have a fixed budget, you have a trade-off in how many within units and how many between units you're going to collect, right? So is it better to have 500 people measured 5 times or 200 people measured 20 times? And some of those questions are conceptual, methodological, and theoretical. Some of them are, so it might be that if you have 20 observations on the same person, you might start to get method effects, and you're not going to really get great data. But you might want 20 observations, as you were saying, to get more reliable estimates and to really get it, especially if you think that change over time might not be simply linear, but people might go up and down, then more time points is going to give you more information about those shifts and changes. So you really, it's really complicated to design a study. I've been kind of fortunate because usually people contact me when they don't know what else to do. So they've tried everything else and they're stuck with their data and they can't make gold out of hay. And so they ask me for help and they're really desperate. And a lot of times, usually I can tweak something, make it work. But if I'm on the design end, it's really challenging. I recently was helping a scholar who was interested in bankruptcy fees and if they varied by court district. Because there's some controversy in the legal world around how much lawyers charge for helping with bankruptcy cases. And there was some perception that some courts are more favorable to lawyers than other courts. And companies can pick where they're going to have their bankruptcy legal proceedings if they have any office. So if it was Starbucks, which is not going to go into bankruptcy anytime soon, they could, anywhere they have a Starbucks, they could do their court case. And so if they say, well, you know, Delaware is really pretty favorable to the lawyers getting paid more, if the lawyers can tell the client, hey, we should do our case here, there might be an effect on the district. So one of the questions was not only what case characteristics influence why some bankruptcy cases cost more than others, but if there are district level characteristics that matter. Now the thing about this legal study is that the districts, the cases are nested within districts. Districts are nested within federal circuits. And there are only 11 federal circuits. So the highest level only had an N of 11. And in effect, your highest level is really your N for purposes of a lot of the power analysis. Walt Stroop actually has been doing some work on this. Raddenbush has a grant doing some work on this. There's some increasing publications on how do you determine your statistical power. Is it better to have more students within a school or more schools and fewer students? And how are you going to use your resources to collect the data? My recommendation to you is if you're planning a study, sit down with a statistician who knows how to do simulation studies and try a bunch of scenarios and figure out what will get you the most statistical power in terms of number of units within and between. With this legal study, we were kind of stuck. There are only 11 circuits. So what we ended up doing is having the cases within districts and then using dummy variables for the circuits to control for those, called fixed effects, taking care of all the circuit effects. We couldn't model it, but we statistically controlled for it. Oh boy. We should take a break. It's been about an hour, 15 minutes. I need a break. You can gracefully leave if you don't want to go. We're going to do a little bit more on the logic, and then basically we're going to be going through some output and figuring out how to use coefficients to answer questions. Thanks for your patience, and I'll be around if you have questions in between.
You know, I still remember very clearly the conversation we had, and he said...
But you can also bring in other information about the physician that's not just from your aggregating data. And so, for example, when we did the labor market study, we got labor market data from a variety of sources. The key, when you have, this is a little tricky. For other software, this isn't an issue. For like SAS, you have one data set. And for your within level unit, that repeats, anything about the higher level, the level 2, is going to repeat with that. In HLM, we talk about 2 data sets because we actually have to create 2 data sets for that software. We have our level 1 data set and our level 2 data set. to link them, you need the level 2 ID, an identification number for the level 2. So for example, if the level 2 is a labor market, you'd have to have the metropolitan statistical area number for that labor market. You have to have that also in your level 1 data. So you'd have to have that would be for every like when I had before, for every person within a physician's practice, the physician number repeated. And that physician number links that person to that physician. And so in the analysis, that you know the clustering by that linking number. So you have to have the same number. And actually this used to be tricky, it's not as tricky now. It has to be like exactly the same. So it can sometimes be a problem if you've created your 2 data sets in different ways. You might have it in string format in one and in numeric format in the other. Can't do it. It has to be the same format exactly. But you need a linking ID number. And it's based on your level 2. If you have a 3-level data set, like before I had cases within districts and districts within circuits, then the circuit number has to be in every data set because I need to, and the district number would have to be to have the circuit number, the district number, and the case number in my 1st level data set, the district number and the circuit number in my 2nd level, and then just the circuit in my 3rd, so that I can link them up. Okay, so it knows where they go. And then people get very creative with how they put together, let's say, a level 2 data set. You can aggregate up some information. My collaborator on the occupation analysis, we did not use data from the people within occupations. This is data, the data set was a National Longitudinal Survey of Youth, because there were not enough workers within each occupation to give reliable information about the occupation. And we did not, we have all occupations, but we did not randomly sample within occupations to get the individuals. We had individuals, and we wanted to link them up to occupation information. So we violate one of the assumptions of multi-level model analysis, which is that you randomly sample your level 2, and then within that you randomly sample your level 1. So, but what we did to create that level 2 data set was we used census data about those occupations. So we used the 35 million people in the census and aggregated workers aged 16 to 64 up to the occupations using the census data, so we had much more reliable information about those census occupations. Then we used that occupation data to link it to the individuals which we had the longitudinal data on. So if you have questions after today, through Mindy, you can either get in touch with me or there's several people that work with the SSP that can help you with thinking about your multi-level questions. And believe me, if you're working on something, you start getting into it, a lot of questions arise that are tricky. So it's, you know, you can read about it, but talking to other folks about it is really useful. And this is, I mean, most of my work, actually this is not true, but half of my work is doing this kind of multi-level analyses. The other half of my work, I do really simple t-tests, ANOVAs, chi-squares, and basic ordinary least squares regression, because I only have cross-sectional data. That's not nested. All right, so here's an example looking at a growth curve, looking at change over time, within-person change over time. I talked a little bit about this study. This is one of the first studies this is the first study I did using multi-level model analyses. And we had 415 individuals with rheumatoid arthritis. We had 7 waves of data on those 415 people. They were surveyed every year for 7 years. And the key question here was, do people differ in their average level of fatigue? Do they differ in how in their fatigue trajectory as it changes over time? And does a history of an affective disorder, AD, that's either major depression or generalized anxiety disorder, does that alter the level of fatigue and the fatigue trajectory? And then in the final analysis, we wanted to know if other, what we call time-varying covariates, other characteristics that are measured at the same time influence that trajectory. So is the history of an affective disorder the key, or is it that people who have a history of affective disorder are more likely to have high distress in the future? So we said, well, controlling for their current distress, do we still get a history effect? Or is the history through the people that had depression tend to have higher depressive symptoms now tend to increase you're distressed now. So we did a mediation, and we did both moderation and mediation to look at trying to figure out what is the mechanism that this history of affective disorder, how does it operate? So here, same questions. Do we do within, between, no, we do both? And we call a latent growth curve because of the developmental history. And we're interested in these questions about level, the intercept. When I talk about level, I mean the intercept, the overall average, or slope, the change in the trajectory. So here is what we would get if we just ran a regression on the stacked data. And actually our results don't differ very much in this particular instance, which is surprising because they do differ in the standard errors. They don't differ in the coefficients. We get very different standard errors, but smaller standard errors by ignoring the nesting. And that's what we expect. We sort of get an artificial, more likely to say it's significant because we have that clustering effect. So you have more homogeneity within each person. So these are not honest results because we violate the assumption of independence. So we could also aggregate up to the individuals. And here what I did is I took the first 15 people and I looked at their over time. And what I did was instead of having the first year be 1, I made the first year have a value of 0 so that my intercept would be more meaningful. That brings up a really important issue we'll talk a little bit about later, but it's really important to think about for each of your level 1 variables, your model. So this is my observation-specific predictors, in this case, things that are measured each year. How those variables are, how the values of those variables are very important because our intercept are very important in understanding what's going on. And let's say I didn't make 0 the first value, then my intercept would be the average fatigue when year equals 0, but there would be no value year equals 0. And so it would be an artificial estimate of what the regression line would be if there was a 0. So it's better to then give the value 0 so that my regression equation, y equals a plus bx, that a will be meaningful. That's an issue that I spent weeks on in my seminar. So that's something to talk to me about. What you can see here is that some people, their fatigue went up over time. Some people, their fatigue went down over time. And some people had very little change in fatigue over time. And they all started at different places. So remember what this looks like. Random intercepts, different intercepts, random slopes, different slopes. So the goal of the multi-level model analysis is to take these intercepts and slopes and make them the outcome to figure out why some people have higher or lower fatigue and why some people's trajectories change differently than others. And our major question was, is it because of this SCAR hypothesis? Is it because of a history of affective disorder? And now that I've met some of you, I feel a little awkward talking about this because you're a psychologist and you know a lot more about this than I do. I was the methodologist on the team, so I don't ask me anything more about the SCAR hypothesis. I just modeled it. Okay, so you with me? So intercepts, slopes, it looks like we have variation. One question we can answer with the HLM output or our multi-level model output is how much of the variance in fatigue is within people and how much is between? I've worked on projects where in the labor market research, if you think about this, it makes sense. Wages was my outcome. And about 97% of the variance in wages, remember what a variance is, we take the mean wage in the labor market, we subtract that mean from each person, square it, sum it, divide it by n, so we get the spread. And that variance, most of it is within a labor market. There are some differences between labor markets. If you compare Lincoln to New York City or to San Francisco, the overall wage trajectory is going to be higher in San Francisco and New York than it is in Lincoln, but only about 3% of the variance in wages is between labor markets. 97% of it is within. And yes, I have a published article about that 3%. Trying to understand why. that variance across exists. But that's usually the first question we ask with multi-level modeling. How much of the variance is within? How much is between? And is it significant? Because if it's not significant, let's say there is no difference between the physicians, then we don't need to think about the physicians. We can just analyze the data ignoring that nesting. There's no effect. And if we're looking at neighborhoods, if there's no neighborhood effect, now that 3% happened to be statistically significant. And so this here would be saying how much of that is within and between. That is one of the questions we can answer. This shows the separate regression for each case. So I have the constant, which is another term for the intercept. Why? I don't know why statisticians do this to me. They torture me. A, B sub 0, constant, intercept. Yes, we have like 5 names for everything. It should keep you, I think it's to keep you on your toes. I don't know. It's because all these different traditions came up with these ideas. So we have, now you can see here, these are the numbers that back up the picture, right? Here's very low fatigue, and about 1% increase, it's measured as 0 to 100%, so 1% increase, a little bit more than a 1% increase in fatigue every year on average. Here, median, the middle of the range, it goes from 0 to 100, no change in fatigue over time, 0. Here we have high initial, this is year 1 fatigue. Why is this year 1 fatigue? Because I coded the variable to go from 0 to 6. So the constant is the mean of the dependent variable, fatigue. When the independent variable equals 0, in this case 0 means the first wave of data. So initial fatigue is 83, and for each year, that person's fatigue went down. They were getting better. This person started out with fatigue in the middle of the scale, and they got a lot better. Their fatigue went down by 3% on average a year. We also could check with 7 data points. We could say, well, maybe it like goes up and then goes down. Or maybe it goes down and then goes up. We could have nonlinear association. So we can just check that the same way we do in ordinary least squares regression by including a square term of our variables. So we'd say we'd have year, the variable that meant 0 through 6, and then we'd have year squared to see if we have significant curvature. We could do dummy variables to see if there's another kind of funky nonlinear association. In this case, we had people ranging in age from 18 to 56, and it was just a slice of 10 years from their life. It wasn't a meaningful time point. Now some of you, I was talking to somebody at the break, if you're doing all of your participants are kids 3 months to 9 months, and you're looking at what happens in this critical time, developmental time, then that might be a really important issue, is do kids like word acquisition. You know, let's say we start with kids who are, instead of 3 months, 1 year old to 2 year old. And we want to see, why do some kids pick up words faster than others? And everybody's experiencing the same very important time period. And it might be that they start slowly and then have a big rapid jump at some point. Or it might be that they go fast and then they start to trail off in their word acquisition. So we might want to think about the different structures of time. So here we can see that there are indeed different intercepts and different slopes. And for some cases it's significant and for some it's not. And so Bickel just came out with a book. And this is a very nice book. It uses SPSS as the main software. And it's multi-level analysis for applied research. He's an evaluation researcher. And it's just regression, exclamation point. My kindergartner's said, you gotta go really loud, Mom, because of that. It's just regression. So, so if you want to take a look at this book, you can. I'll pass that around. Basically, he builds up teaching multi-level models using this approach. So now, conceptually, not actually, the software doesn't do this, but conceptually we have 415 intercepts and 415 slopes because we have 415 people. And now we can analyze that as a data set, and we can conceptualize those intercepts and slopes as latent variables measured from the information within that person. And more reliably than, because we have multiple observations. And then what we're going to do is pool all that information into an overall average, which is called a fixed effect, for the overall intercept and the overall slope for all of those people. And then we're going to have an error term at level 2, which I'll show you this equation in a minute, which is going to be our random effect which is going to summarize the spread around that intercept and slope. So what's the range of values that people tend to have for their intercepts and for their slopes? And is it a narrow range or a wide range? Okay, so the first question I told you is within and between, and nesting tells us about that. This is also just looking at just the person level analysis instead of all those different estimates. And here, using just the person level, we don't know anything about the change over time. You couldn't even estimate it because it's when I aggregate the data up, it's an average for that person. It doesn't vary. And I know you all know this and you're going to laugh at me for saying this, but variables have to vary, right? And so if we get that person's average time in the study, that's fixed. It's not changing. It only changes within the person. When we look at the person, it doesn't change. So we can't actually even answer questions about your trajectory at the person level. We can only look at, does a history of affective disorder make a difference in their fatigue? So we're going to use both at once. And so here is what I'm going to switch notation now. Instead of using A, I'm going to use B sub 0 because that's what they use in the multi-level model world. And actually for over time they use pi. I don't know why. So pi is terrible because pi actually has a mathematical meaning. And so I was recently looking at a formula, and I swear I did not know if they were using pi to mean the proportion in the sample because I was looking at a dichotomous outcome, or if they were actually using pi 3.21 forever. And I wasn't sure how to solve the equation. But why pick pi? Anything else? There's a lot of other Greek letters. Why pi? That actually has a meaning, and I have to figure out which it is. Anyways, so here we have the constant slope between the intercept and the slope and the error term. And now we have our level 1 and our level 2. So we do 415 of these. We have 415 intercepts. We can say, do the intercepts depend upon history of an affective disorder? We have 415 slopes for time, measured over here. And now time is my outcome. And I can see if that slope differs by history of an affective disorder. Now let's just think about these equations for a minute. This coefficient here is going to be, I've said this several times during this talk. If you were my graduate students, I'd make you say it, but you're not. You're nice people that are spending a Friday afternoon with me, so I'm going to tell you. So this is, the intercept for this equation is the mean of the dependent variable, so it's the average intercept. It's the intercept of the intercepts, the average intercept, when this variable, history of an affective disorder, equals 0. And this is a dummy variable, so 1 means you have a history, 0 means you don't. So this is the average fatigue for a person without a history of affective disorder. And this is the difference between people with an affective disorder and without. The value of this coefficient is going to tell me if and how people with an affective disorder differ in their average, it's actually their average initial fatigue. Why is it initial? Because time is measured 0 through 7. So when time is 0, it's the first wave. So all of my intercepts are the fatigue for people in their first year. And so these two coefficients here are called fixed effects. This is the average of the intercepts. And this is the average of the difference in the intercepts for people with an affective disorder. This is the average, these are all the slopes. This coefficient is the average of the slopes. It's actually a weighted average. It's weighted by how many observations there are and how far up that case is. This is very special because now I have a variable predicting a slope. That should ring a bell. Where have you heard of a variable modifying a slope? It's an interaction. Most of you, if you know regression, should know a little bit about interaction terms, where we want to say, does a relationship depend on another variable, sometimes called z? Is a relationship between x and y depends upon the third variable, z? If it does, then we have a statistical interaction. So here we're saying, does the relationship between time and fatigue depend on whether or not you've had a history of affective disorder? Are you with me on that? So if you don't know about statistical interactions, I can't kind of teach that whole concept now. But that's the basic idea. So does this relationship depend on a value of another variable? In multi-level modeling, this is called a cross-level interaction. I can have within-level interactions. So over here, I could have a variable for distress, psychological distress in that year. So I can say not only is it just time, but if the person has higher distress in that year, do they also have higher fatigue? And if they have lower distress in that year, do they have lower fatigue? So it would be a time-varying covariate, something that's also measured every year. And if I did it, and then I might have pain, and then I could also do an interaction of pain and distress. That would be a within-level interaction. And here, I could add aggregate distress. So not only did you have a history of affective disorder, but maybe your history was 20 years ago. So what about during this 7-year period? What was your average distress across those particular 7 years? So I could have distress changing over time, and I could also have your average distress over that period measured at the person level. That's a person characteristic. Change in distress is a characteristic of the wave or the observation. Average distress is of the person. If I did that, and then I did an interaction here, that would be a within-level interaction at the person level. This is a cross-level interaction because I have a level 2. It's got 2 subscripts. This is for person I and observation I and person J, modifying with level 1 slope. So going from level 2, modifying within level 1. So you can see that this is very powerful. We can answer a lot of questions. We can find out how within characteristics are related. We can find out how level 2 characteristics are related to the outcome. And it's tricky because you're saying, wait, I'm not measuring the outcome. I'm measuring the intercept. But the intercept is the average of the outcome. So I know it's tricky, but that's how it works, right? So I'm actually predicting the outcome here. And then here I'm saying, and do those within slopes depend on characteristics? I do not have to have these parallel. I can have a variable here that's not here, and a variable here. I actually can't have a variable here that's, if I have a variable here as a modifier, I actually also have to have it in the intercept model, because that's a basic rule of interactions. You have to have all of the component parts in order to also have the interaction. But I don't need to have variables modifying all my slopes. I can have different equations for different outcomes. This is a very basic model. I can add many variables here. Every time I add a variable here, I'm going to have at least an intercept down here. Now here's another thing that's tricky, and I told you I'm giving you like 5 or 6 weeks and 3 hours. So this is just a taste of it. I don't think you're going to walk away from here going to publish something on it unless you're not me. You can figure this stuff out much quicker than I could. We have these are also linked variables. These are the error terms. They're also called random effects. And in the multi-level model, these are very important. Here we have a regular error term. Right? This is the observed minus the predicted. That gives us how far off we are. And predicting our outcome based on these variables. These error terms here are specific to the person. So how different is this person from the overall average? This is the overall average, and we can actually save these out. These are called residuals. What's left over, residual. And we can model them. We can say, why are some people higher or lower? We can use them to think about higher or lower. And we can also try to explain them. So every time I add a variable to my model, this should get smaller. Because I'm saying why that person is different than the overall average. Okay, so these are called the random effects, or the variance components, varying around the fixed effect. That's the multi-level. You got it? Yep. Great. We were talking at the break, so. All right. Whew, this is exhausting. Even though I'm really excited about multi-level, can you tell? I think they're pretty cool. They don't do my dishes, though. Okay, so we do a lot. All right, so statistically, I'm not going to go into it, but this is what I took. I actually did the Brick and Raudenbush workshop twice because I'm a slow learner. This is what I took away from the statistical estimation. There's a chapter in their book. I have their book too. Actually, I should pass around some of these other books. This is the Juke Hawk's book. I think this is an excellent book. That book, the Bickle book, is very basic. This is how to get students to drop your grad seminar. Have them open this book. They get really scared from this. But these are the guys that I learned from. And this is in between. This is sort of, has the stats. He's a stud, but he's really good at explaining it. So if you want to take some of these, I need these back up. So they all have a chapter. Those two have a chapter near the end. The Bickle book doesn't have a chapter. They have this really scary matrix algebra, lots of differential equation type things, explaining the iterative Bayesian Laplace estimations that make this magic happen. And here's what I took away from the workshop. Trust me. So I do. Okay. But actually, though, if you get into binary outcomes, it is really nasty. And they are duking it out. The statisticians are duking out the binary outcomes. Because the estimation procedures, there's logit-link functions, C-log-log functions, Laplace estimators, different kinds of Bayesian estimators, and they're doing a lot of these simulation articles comparing these different kinds of underlying estimators and when they work better or worse. And sadly for me, because we have to finish this binary outcome paper, they haven't decided what's best. So we're doing it. Okay. Centering, I already went through that a little bit. Basically, because your intercept matters so much, you really have to think about it. In the multi-level, in the HLM software, every time you enter a variable into an equation, it asks you, do you want to have a raw score? Do you want a group mean center? Or do you want a grand mean center? It's like Indiana Jones in the Temple of Doom. You know, I'm always like, am I going to make it through this test? Am I going to pick the right one? It's terrible. But now, this is something that it's been very complicated for a long time, and now I think it's pretty much sorted out. Group mean centering basically means using the unit-specific mean. So basically centering. So for the example I just gave you with fatigue, it would be deviations, just subtracting each person's mean from their own scores. Grand mean centering is subtracting the overall mean from each person's score. So when you group mean center, you take away your ability to look at between differences. When you grand mean center, you have information about how, for each wave, how far somebody else is off from their other observations, how much they've changed, and how far off they are from the overall average. So you retain that between information. Hoffman's article talks about in business when you should use group or grand mean. Aiken, West, and DeLieu, or Aiken, DeLieu, and there's one of the articles in there. They have a really good mathematical article. It's kind of hard to read, but basically they show that grand mean centering is mathematically equivalent to raw score, but group mean centering can really cause you a lot of trouble. There is a trick, and I hinted at it before, where you can group mean center within, and then include the aggregate mean at level 2. So for example, if I want to know, does it matter if somebody has more or less distress than they tend to have, their own mean? Now they might tend to be a person who has low distress, or a person that has high distress, or a person that has average psychological distress. But maybe for their fatigue, what matters is not whether or not in an absolute sense they have high or low distress, but what matters is if they're deviating from their own mean. And if that's what you're interested in, you want group mean centering. But if what matters is not only that they changed their distress level, but that they changed relative to what's sort of normal for the population, the grand mean overall, then you want grand mean centering. You can have both. See, it's so great. I'm just realizing just how it is. You can have both. You can have it all. If you group mean within and you include that person's mean at level 2, then you can say, here's how they are. Does it matter if I'm different from everybody else? Or does it matter if I'm different from my own average? You can actually model both simultaneously. You need a lot of data points for that, but you can find out. And that's very powerful, and that's actually what we did in this paper, where we looked at, does it matter if you deviate from your own distress, average distress for fatigue, or does it matter that you tend to be higher or lower than the average for the population? So with every variable, with every study, you have to decide how you're going to center, or if you are going to center, including dummy variables. Luke's has a really nice, I can't find it, I think I lent it to somebody. Luke's has one of those little green sage books, a very nice introduction to multi-level modeling. And he has a thing about centering. What does he have about centering? I can't remember, but he has a really nice introduction to multi-level modeling and centering. He doesn't do longitudinal though. Okay, we're going to talk about error terms in a minute. There's so much more. This is basically the end of my overall talk. And then we're going to do a little bit with, we're doing okay. Actually, we're doing really good. Because it's not going to take long to go through. Are you doing okay? Okay. I think some of this will come together when we look at output. This, from the study, this example that I've been giving you, I actually discovered a new tool in PDF. It's the snapshot tool. And I can take a piece. Do you already notice somebody's laughing? This is a beautiful thing. See, you can take a piece of a published article and plop it in your PowerPoint. Now, I wrote this, so I'm stealing from myself, but it's still very sweet because it's formatted so nicely. Can you see this from back here? Yeah. Okay, because it's longitudinal, remember what we have pi. I was thinking about pi the other day, the diameter to the radius. I'm thinking it's about circles and cutting it in a line, dividing a circle. I wonder if the number pi has anything to do with pi. It's like apple pie. Anyway, seems like it should. Okay, so it's a little bit more. Here's our basic equation, but now instead of having b or gamma, we have pi. Why? So we know it's a longitudinal. The truth is, when I did this analysis in 1998 and 1999, HLM software didn't have a separate longitudinal component. So it actually, we didn't have pi. And we just used b and gamma. So here we have the subscripts. So I have the outcome is fatigue for person I at time t. And the intercept is pi sub 0 I for the person I. And the pi's, for the first coefficient, the 0 coefficient, the intercept, pi naught for person I, and plus pi sub 1 for the first slope, person I, and A stands for time. That's just the convention in the book for time 1, person I, and then the error term. So what this is showing is that this is within a person, the within person equation. This is also from the same article, and this is showing that intercepts are the outcome. I have 415, and this is showing that the slopes are summed across all of the individuals, and then this is my slope model. So this is notation that's taken from Raudenbush and Brick. You can also have complex error structures. Specifically with overtime data, we might say that observations that are measured closer in time will be more similar to each other than observations measured further away in time. Oftentimes, researchers use what's called an AR1 error structure that assumes that in doing the calculations for creating estimates of standard errors, mostly the standard errors, that observations closer together will be more highly correlated than further apart. So not only do you have nesting, but you have a particular structure. You can have other kinds of structures such as compound symmetry. The multilevel model textbook takes you through all the different common error structures. It's sort of a world that's you basically have to try out different error structures and see which one fits best. And there's some fitting estimations you can do. SAS has a much more flexibility and a lot of different error structures you can try. It's very cumbersome to do this in the HLM software. But it's important to make sure that your findings are robust across different error structures and that you use the appropriate error structure. So here's an example of HLM output. This is the fixed effect, and I'm trying to use that language a little bit before to get you into the habit because the output is set up this way. This fixed means it's averaged across all individuals. So this is the 47 is the average fatigue in the first wave for people who don't have an affective disorder, because the dummy variables has an affective disorder. This is showing that people that have a history of an affective disorder have on average about 10% higher fatigue than people who don't. And because T is bigger than 1.96, and I'm going to say this is statistically significant, and it's actually at the 0.001 level, they're nice enough, even though they never refer to it, they're nice enough to give you the actual probability value. They only ever talk about this column. And I decided when I was at that workshop that real statisticians only refer to the T's, and you're supposed to have the whole distribution in your head. And then here is my slope. So G1, here G sub 0, 0 is the intercept of the intercepts. And here's for the intercept model, the first predictor. Here I have the first slope. It's the intercept for the first slope. So this is the intercept of the slopes. And then here is the first slope, first predictor. So this is the average change in fatigue over time across all individuals. And it's a little more than 0.5% because the outcome is in percentages. So for each year, on average, fatigue only goes up by about 1%. For people that have an affective disorder, that growth is actually a little bit lower. So they start higher, but they get worse a little bit more slowly. So there might be a little bit of a ceiling effect there. But the difference is not statistically significant. So what we found is that an affective disorder, history of an affective disorder, is associated with higher fatigue, but the growth curve, the trajectory, is consistent for everybody. Does that make sense? No? Did you expect it to be worse, or they should get worse faster? We thought they were going to get worse faster. But we think it partly is because they start high, they didn't have as much room to go. That's called a ceiling effect. Here are the variance components. Remember, what you should be picturing in your head now is that equation that has the level 2 equation where the intercept, the B sub zeros are the outcome, and then you have the U sub 0. This is the U sub 0 part. The variance of those U's is what we're looking at here. The variance components. It's called tau squared, and I don't know why. And what we would normally do in beginning a study is do an analysis without the year slope. We would have no predictors. We would just have the intercept and the error term. And the first thing we would do is look at these variance components here, add them together to get the total, and then divide by the u sub 0, the between variance component. So we would add the u sub 0 and r, the between and the within, to get the total variance in fatigue. And then we divide the between by the total. And that would tell us the proportion of the variance between. And then sort of minus that's going to be the within. So in this case, I think it's about 60-40. About 60% of the variance is between people, and about 40% is within. That alone is very interesting. I had some students in communication studies that were looking at data where they had 3 family members participate in an exercise of telling a story, a family story. And they had characteristics about the family, their average education, their wealth, how long the parents had been married, how many kids were in the family, a bunch of characteristics about the families. And then they had characteristics about each child, the child gender, the child age, grade of school, different things about the child. And they had this data, and they had analyzed the data at the family level. Remember that flat tile? They had family level data. And in their area of research, nobody had ever said, I think their outcome was, I totally forget what the outcome was. It was something about like satisfaction with the storytelling or family dynamic. The thing was satisfaction with the storytelling. No one had ever thought about, well, how different do family members feel about it? There was sort of this assumption that a family there would be a family, that context, would be satisfied or not, or have higher or lower satisfaction. And then all of the members of the family would feel the same way. Okay, have you seen a teenager lately? Right? And these were teenagers. You're kidding me, right? You've got like a sullen 12-year-old, and they're going to be like, oh, I'm so satisfied with this conversation we just had. I just love you, Mom and Dad. You know, the parents might feel really good if they said anything, right? So I was like, I don't buy it. I don't buy that every family member is going to have the same satisfaction level. There's got to be some variance among the family members. And you're ignoring it in your analysis. You're just analyzing it like this family as a unit is working. I'm not buying it. So they set up the data, they ran a little multi-level analysis, and they found that about 30% of the variance was within the family, and about 70% was between. That alone is news. Just that. The same as that stalking. You know, if there's variance within a person and their fear from stalking, that alone is news to say, you know what, it's not the person, it's the person and the stalker that matters. And so just finding out that statistic, how much within, how much between, can often be very important and revealing. And then you want to know why, right? Why do people vary within and why they vary between? So here, really the story was there's a lot of variance within. People's fatigue changed year to year. And there was a lot of difference between. So we had predictors at both within and between to try to explain why. What we also found out was that the slopes vary. And you saw that in the picture. Remember the picture we saw with some moving up, some going down, some going flat? And this chi-square test is telling us that that variance is statistically significant. Now with the legal study that I was just doing, very few of the slopes are statistically significant. It was actually very consistent across the districts. So very little between district. I think it was actually, it was only 10% between districts and 90% was within the district. It was really the cases that were driving the fee level. It wasn't the districts. And we were actually able to explain all of the district level effect by the fact that, like New York City and Delaware had much higher fee cases. So as soon as you controlled for the size of the case, how big the company was, you explain away that variance. And that's one of the things we're trying to do, is we're trying to include enough predictors that we can make this be non-significant. We can explain the variance between and within and say, it's just like an R-squared. We want our R-squared to go up. We want this variance to go down. We want to pull it out of the variance and put it into the model and have it be part of our model. people who use SAS or Stata, I think M+ as well, they don't think in two equations or multiple equations, how I set it now where I have the within an equation and the between equation. They think in one equation that's called a mixed equation. So this is an example of a mixed equation where you take that level 1 equation, in the output you never actually see that. Why? Because I have to have 415 of them. And I don't need it. I've summarized those 415 equations in gamma 0, 0, gamma 0, 1. Those are my fixed effects. The average intercepts average slopes. And in my error terms is telling me how much spread there is around it. So I don't need to see all 415. I have a nice succinct summary of it in my equation. So you can see how by substitution you can have the intercept of the intercepts, the first predictor of and then there's the first slope down here. This is the intercept for the first predictor, level 1 predictor x. And then here is my level 2. Luke uses W to symbolize a level 2 variable on the intercept, and this is on the slope. And then the random components are here, that now I have a complex error structure with it. I have 3 error terms because I have 3 equations. If I add more variables at level 1, I need to add more equations or add more random. Every time, now that's not true actually. I have to add more equations, but I have a choice about whether or not to have the error term. If I take that error term out, then I'm saying everybody has the same intercept and same slope. I'm not letting it vary. And one of the things you can do with multi-level model analysis is that previous slide that showed the variance components, if that was non-significant, I would fix that. I would take that error term out because it's not going to converge. My model's not going to fit. So you run it and say, is there a significant error term? And if there is, you leave it in. If there's not, you take it out, and you're basically, what you found is really important. You know, if that if that time slope might be significant, then remember those 4 charts I showed you? Then you'd have a case where you have different intercepts but the same slope. So everybody would have the same slope. You'd be forcing it to do that. But you would only be doing that after you checked and you found out that's actually the case. Does that make sense? So in the HLM software, there's actually a toggle where you click on that to make it go away, or you click on it to be there. And for each equation, you have to make a decision. Am I going to fix everybody to be the same, or am I going to allow it to randomly vary and for each person to have their own value? And you summarize that in the variance components. So that's what's called a mixed model equation. So there are just 2 different ways of capturing the same information. People who learn how to do multi-level modeling through SAS are more comfortable with the mixed model equation. People who, and those kinds of software, people who use HLM think in 2 levels and multiple equations. They're mathematically equivalent. It's just what is more intuitively comfortable for you. I find the mixed equations not very comfortable, except for there's one situation where we're using it because it tells us the story better. So, as I said before, the early books are like the Rowdenbush and Brick and the Jukebox, and there's also Moncref de Liu and Aiken have an introduction to multi-level modeling. They really kind of scared the pants off people and kind of made people go, forget this. The newer books, the Luke Sage book and the Bickle book, are very accessible, very practical, take you through how to do this and make sense of it. These are 2 very good articles, specifically for intervention research and health research, that they don't go into as much detail as I've done here, but they take you through why to use it and what are some of the benefits and how to do some of it. We don't have time to talk about really good basic data analysis. You should really explore your data before you analyze it. Some of the things I did there, do graphing, scatter plots, visualization, your expertise. You should really pay careful attention, look for outliers. And not only do you have outliers within, but you have outliers between. So you have to think about both levels. You have to think about unusual values within a person, if their trajectory is going along and their fatigue, was, 40, 45, 50, 80, is that a real value or is that an error? What's going on there? And then you could have your level 2 unit could also be an outlier. And the HLM software has some really nice graphing features for exploring your residuals. And in this case, residuals are, when they're level 2, they're person specific. They're not just how far off from the regression equation that level 1 sort of we think of as OLS, but also how different that person is from everybody else. I talked a little bit about power analyses. You also need to do assumption checking. You still have normal distribution of the error term assumption and homogeneity of variance. You can check that with some of their graphing features. And then nonlinear outcomes, avoid them if you can until they figure out these estimations. I think it's really nasty. Okay, let's look at some. These are some other things I didn't have time for, but I mentioned. Let's look at some outcomes. Oh, if you're interested in change in particular, this webpage, this longitudinal Sterling English, it's a beautiful thing. They have all of their command files in Stata, SAS, and I think HLN. They have annotated output. They have great PowerPoint slides. I love this webpage. And I've only talked to you about growth curves. You can also have a change model where you don't have time as a predictor. Because maybe you don't care about time. Maybe what you care about is a change that's happening and how that change affects the outcome. So with another study that we did, we looked at if you experience negative events, does your mood change? We're not interested in minutes from the morning or how long you've been awake or the time throughout the day or even the days over the time. We're just saying if you have a change in this, do you have a change in that? And that's a sort of a different way of thinking about change. It's not a trajectory, it's a change model. And with this, with the individuals within occupation study, to test whether we had unobserved heterogeneity explains selection, that maybe people who are more likely to select into occupations that are higher percent black are also more at risk for injury because of who they are, not because of the occupation. We did a longitudinal analysis to see, as people change racial occupation structures, does their risk of injury change? Even though everything about them is the same. Right? So we're fixing who they are, so it can't be selection. And as they change racial, and 80% of the people in the sample did change racial occupation structure, so we could model that change. And what we found is, indeed, if we go to a higher percent black occupation, risk goes up. Go to a lower percent black occupation, risk goes down. Even controlling for everything about that person. Their education level, their training, not their experience, that changes slightly. So it's a much more powerful test. We weren't interested in time there, we were just interested in change. So it's another way of thinking about using multi-level models for change. Okay, you ready for a little bit of output? No. Oh, so good. You guys are just great hanging in there. Any questions before I turn to this? Okay. What I need you to do now is, and if you're interested, what I'm going to take you through is from an article that was published in 2001 in the Annal of Behavioral Medicine. And if you want to, you can email me and I'll send it to you as a PDF. Not all, but most of the articles on the resource handout, I have electronic copies of a lot of them. And you can get them, a lot of them are in JSTOR now too. But if you can't get them, some of them are a little more obscure. I interlibrary them a lot. Okay, so what I need you to find are the output that looks like this. It says HLM2. And because I did this back in 98 and 99, this is from an earlier version of HLM. Do you have a packet that looks like this? Do you have some output that looks like this? It's going to say fatigue based. Oh, it looks like. Does it look like this? Mine I just printed up in my office. So it's going to say fatigue baseline equals number 1. Does it look like this? Yeah. Yes. Okay. Sorry, I had the wrong. Okay. We actually have 5 outputs. And what I did is I just printed off the output that I used for this published article. It's going to look like that. So there's gonna, I'm gonna give this, do we have an extra set of this, or did we use everything?
Yeah, I've got an extra set.
Is it outside? I can get it. Yeah, I got it. I just want to make sure I do the same as everybody else. And then I have this little table like this, and I forgot something kind of important on this table. Right where the row, the third row where it says fixed, what you need to do is have the column headings E, S, E, and T. So for the B coefficient, so this table here, okay, and what we're going to try to do is see if we can read the output to, and I'm going to pull the output up here, to take information from it. So the first thing we want to know is, and I already showed you a little bit about this, at the top of the output, let's see if I can pull this up here. So can you see that a little bit? All right, I named this the fatigue baseline model. This is telling me that there's 415 units. You always want to check that. You want to make sure that you have the number of units you think you have. I'm not going to go through this here. I can show you a little bit. This is what the HLM software looks like. And this is what it starts off looking like, just a blank slate. And then they list here the level 1 variables and the level 2 variables. And it doesn't let me go to level 2 unless I give it a level 1. Before I got to this stage, I had to create what's called a sufficient statistic matrix, or an MDMT is what the new name for it is. And so what I had to do is I had to go and create a new, make a new MDM file where I actually brought in, I told it I was doing a 2-level. I had to name it, and I had to bring in the first data set. Name your data sets level 1, level 2, it saves you a lot of time. So this is affective history level 1 and affective history level 2. You actually choose the variables, and this is the ID number that links it to the person. So this is observations within people. And I selected fatigue and distress, year 0. I don't have to bring in all of the variables. I think there is missing data. And then level 2, I chose variables, linking on the ID. This is no affective history. These are my depression, anxiety, and comorbidity. And having an affective history. So I have to combine them. Oh wait, good, I want to do that. Just to give you a little feel for this software. Click that, it makes it, and it shows me that I have 2,905 observations within 415 people. I can look at those statistics again. Sometimes you'll get an error message. If you have observations that don't link up to a person, or a person that doesn't link down to observations, you'll get an error message saying, you know, you're missing somebody at level 2, you're missing somebody at level 1. You should take a look at that. You can't have any missing data at level 2. You can have missing data at level 1. So you have to deal with your missing data before you bring your data in. You can do multiple imputation in HLM. You could bring in 10 of these, and it'll combine them using the appropriate algorithm, the Rubin's rules. If you have a lot of missing data issues, I strongly urge you to look at the SSP webpage presentation by Levi Lippe. He covered it all and did a great job. So here, this is a good, let you stop and check to make sure that your level 1 variables and your level 2 variables make sense. Your means and standard deviations make sense. Your ranges make sense. You don't have any problems with your data. If you have very large data sets, we were working with the census, and we had several million cases. A couple times I accidentally stopped the process of making this MDM file. You saw how quickly that went, right, with this many cases. I didn't realize I went like this, and I stopped it before I had finished doing the procedure to combine and make. It was actually in the iterations. I was getting really funky ends in my output. It was a good thing I checked. I talked to the programmer, Condon at Harvard, and he worked on it for like 2 days, and then we figured out I just didn't have a fast enough computer to handle what we needed to do, and I needed to let it run for like 3 days. Okay, so when I do that, I've created a new data set. I'm not going to use that one. I'm going to use the one that I had before. And so here, I'm going to take, if I take this, I have to put in my variable, and as soon as I do that, you saw that, I put in one variable, it created 2 equations. Just that one output, and it set up that I'm going to have an intercept, an error term, and at level 2, I'm going to have the fixed intercept and error term. By just putting in the dependent variable, it automatically did that. If I want to fix this so that it doesn't vary across individuals, I can toggle this out. I can toggle it in. And then there's other things you need to do about iterations, estimation. I always use full information maximum likelihood for a reason that it's kind of advanced. Most people think restricted is better, but there's some things you can't do with it. You can label things. You have residual files. They're telling you right up front. You want to explore your residuals. You want to check for outliers. You want to check your assumptions, because your statistics are only as good as your assumptions. And then you can pick your distribution. And to run the analysis, save it, and it's iterating. And then this is the worst thing about this software. Where did it go? Most software, it pops up, here's your output. No. And it's not like you just click a button and it's there. No, they hide it. They totally hide it. This drove me crazy. I go, I just ran the model, where'd it go? You have to go to File, View Output. That's intuitive, right? That's a really good design feature. Okay, so anyways, well, commentary along the way. So that's pretty much how easy it is to get from 2 data sets to analyzing it in HLN. There's actually a lot of trickiness along the way, but if you need help, we'll help you. Okay, check. You've got 415 observations. This is how many iterations it would allow it to do. I picked maximum. Here I have restricted maximum likelihood estimation. I have a choice between restricted and full. I'm not going to go into that here. This is really nice. It's telling me here's my level 1 and here's my level 2. And my output is really only going to be G00 and U0. I'm not going to see this part, at least for the most part. In the older version of HLM, it was easy to get, this is actually saying for person 105, here's their intercept. It's giving me the first 10 intercepts if I wanted to look at those raw values and get a feel for my data. It's a really nice feature for getting a feel for your data. It will give you the whole equation. If you had slopes, it would give you the slopes too. Sigma squared is your variance component by another name. See how it's 442? Here's my variance component for the within model. And it gives it to, I don't know why they give it to you here too, but they do. Here's my fixed effect. So by now you should be looking at that and you should say, oh, wow. The average fatigue overall for everybody is 51.21. How do I know that? Because this model is just saying what's the mean fatigue, what's the intercept across everybody. And down here, the variance, and then this is actually the, they do the starting values and then they do it again after they've done the estimation. Here's my, it's settled on this coefficient. Here's my standard error, my t ratio. Don't really care that that's significantly different from 0. I have no hypothesis about that. Here's my variance components. I can get my total variance by adding those together. What is the variance? It's the spread around the mean, how much deviation there is. So if I add those together, I get my total variance. If I want to know how much of the variance is within, the u sub 0 is my my between. My u sub 0 is my between. I divide 390 by the total, and it's going to be about 60%. So on your little handout, what you could do with these different models is write down the intercept for the baseline model. This is the baseline model. So it's going to be 51.32. And you can write down the standard error at either the p-value or the t-value. And then way down at the bottom, I have the random components. And what I've done is I put all the possible variables we're going to have for all 5 models over here. So we go the model building strategy of adding in variables. We can see what happens as we go along. This is a standard way of displaying regression coefficients in publications. Also, you'll see down at the bottom I have deviance and parameters. The deviance statistic is -2 times the log likelihood, which is a standard summary statistic for maximum likelihood estimation. It's summarizing the overall model fit to the data. What is my model? My model is a mean and a standard deviation. It's basically the average fatigue across the people at the variance within. So that's my very basic model. This has no absolute meaning. It's only useful for comparing models. So I write down my baseline deviance, and that should be getting smaller as I add in variables, because I'm explaining more of that deviance. And I have 2 parameters. I estimated the intercept and the random variance around them. My next model, I bring in time. So this is the fatigue baseline growth model. I call it that because in the article that's what we called it. So if you look at the article, you can link it up. So again, I have 415 observations, and now I look at my equation, and I've added year to my level 1. So now I have another equation down here. I've added B1 as my outcome, the slopes. So this model is going to tell me the average intercept, the average value of fatigue in the initial wave, because I coded year to have the first wave be 0. So there's my level 1 model. I'm actually going to be these 4 coefficients here, gamma 0, 0, u sub 0, gamma 1, 0, and u1. This is what's going to be in my output. That's what I'm going to see in my output. That's going to tell me the average intercept, the variance around that, the average slope, the variance around that. So where do I find that? I go down to the bottom. And I think I bolded this one. Yep. So final estimation of the, by the way, I did scrunch up this output a little bit. Brick and Routerbush actually spread it out more, but to save paper, I got rid of a lot. So it's kind of scrunched up on your handout. They're not that cool. They give you a little space. But I didn't want to, I already was killing a couple trees. So here, I have my, now in the initial wave, fatigue was a little bit lower. It's 49. Before it was 50 something. But before it was for all waves, all people. Now I've just got my initial. And this is my slope, my growth curve, my linear growth curve, 0.51. So for each year, on average, people's fatigue only went up by 0.5%. But that slope is statistically significant. I know that because my t is greater than 1.96, my p is less than 0.05. What I didn't tell you before, we can take the variance component and calculate a confidence interval around this intercept that will tell us how much spread there is. We can do that for both the intercept and the slope. Basically, it's the square root of the variance component times 1.96. What's the square root of the variance component? It's the standard deviation. Where's the standard deviation? The first column. So I don't know why. Don't you think they would put the variance component then the standard deviation? They're not thinking like we do. I don't know how they're thinking, but they're not thinking like we do. So you have to go back here. So what you should, if you have your handy dandy calculator, which I know you all have with you, your little statistics calculator, because if you're here, you're kind of a geek. And that's a compliment. And we have 523.258 square root 22.87. Okay? So what's the square root of the variance? It's the standard deviation. Multiply that by 1.96. Why 1.96? It's the t for a 0.05, it's a 95% confidence interval. And I get 44.83. And so something is wrong. I always do this. That should be, it might be another, where's the brick and mortar book? They're accumulating back here. That's the portion excluded. Chapter 4. Ah, 878, so it's the square root times 1.96. Yeah, it just must be really big spread. That's right. Let's do it for the slope. I think that it's just a huge spread. So, the range goes from, so let me do that again. 22.87 times 1.96, it's about plus or minus 44. So that average fatigue, that 49, the range, the 95% confidence interval is from like 5 to 95. It's a huge range. There's a huge spread in fatigue. The slope, however, that's going to be 2.758 times 1.96 is 5. So we have 0.5 is our point estimate. It's the average slope. But some people have much steeper increases by about 5.5 up to 5.5% a year. And some people had much steeper decreases. They went down by up to 5. So the range around that point estimate is 5.4. So that gives you a sense of the spread that those 415 people had around that average slope. And in both cases, that the variance components are statistically significant. So now we're going to add some variables. And if we compare our variance component here, that 523, to the variance component that we had in the previous model, oh, this is one of those things. Okay. It should go down, but it doesn't, right? It goes up. It's because it's over time. Jupox has a whole section, that Jupox book that I had back there. I've read this several times, and I get it every time I read it, but I can't tell you why. But it has to do with how little information there was within, that there's only 7 observations. And so when you add time, you actually increase the variance. You don't decrease it. So in most models, that's going to go down. The variance component is going to go down. But now, usually with growth curves, it goes up when you add time. But then the next model is going to make more sense. So the next model, you are such troopers. We're almost done. You are just great hanging in there. Now this one, 508, is smaller than the 523. Now we'll start to go down. But there's a mathematical reason why it almost has to go up when you add time. And Jupox does a beautiful job of explaining it, and I don't have it with me here. But now we'll by adding in variables. Now here what we did was we added in the dummy variables for a history of an affective disorder. And even though there is significant associations with the intercepts, we do explain, we go from 523 to 508, where parameters only went up by 1. But and so that is probably a significant reduction in the variance component. We are explaining some of the variance between people and fatigue, but not a lot. And then the next model, what we did was we collapsed, because there wasn't a lot of difference between the affective disorders, we combined them in just any affective disorder versus not. And basically we have the same variance components, but we get a more parsimonious model. And then we had the question about what about contemporary distress. And so in the next model, we added in a new level 1 variable. If you look at the fifth model, that should be the final full fifth model. If you look at the regression equation, we have now two predictors at level 1, time varying covariant distress that changed every year, or could change every year, and then the year variable. And then we had the dummy variables at level 2 for each model. These are called parallel models. They don't have to be parallel. They don't have to have the same predictors in all of them. But in this case, we did. And we have variance components in each case. If you look up here, it'll also tell you my centering decisions. I group mean centered within, and I gram mean centered between on distress, so that I could look at that within if what matters is deviation from your own average, or if what matters if you're higher or lower than everybody else. So this is the summary of those centering decisions. And if you look all the way at the bottom, what we're really focusing on is this column right here. So if you notice, the B0, B1, and B2 from our level 1 model, as you look at this output, let me just take you through this a little bit. This is saying, for this level 1 coefficient B sub 0, here's the fixed effect. Here's the average across everybody. So these gamma coefficients are actually what we report. So you're basically sort of reading those. This is the first equation, the second equation, the third equation. This is for the B sub 0s as the outcome. These are predicting the intercepts, predicting the distress slopes, and predicting the time slopes. We've also added not only average CESD across the 7 waves, but we actually also included how long they've had their diagnosis, to see if it mattered how long they've had their diagnosis, trying to explain the variance in intercepts and slopes. If we look down at the variance components, it goes from 523 down to 313. So current distress explains a lot of the variance, a lot more than time itself. And what we find in the paper, we do a Kenny and Barron mediation model where we walk through all the appropriate associations and find that why do people with a history of affective disorder have higher current distress? I mean, fatigue, it's because they tend to have higher current distress. It's not just because of that history, it's because they also are more likely to have higher distress now. That's the mechanism. It's not some lingering scar, it's the ongoing dealing with distress. Now, do you have any, is this making sense of the output? As you look at the output, can you kind of find coefficients that you need? Here, the thing that you want to do, here's the big trick, is take these equations up here that they give you. You actually want to write this equation out before you run any models. And each of these gammas, the G's, you want to say, what is that telling me? And then keep your eye on the gammas, because those gammas, that's what you're looking for in the output down below. So I actually, when I teach this seminar, have my students write out those equations and then sit down with their output and fill it in. And before they even run the model, you want to say, what is each one of those coefficients going to tell me? And I've done that about 50 times this afternoon. I've said, this is what gamma 1, 0 means. This is what gamma 0, 2 means. This is what gamma, this is telling me, you probably could all recite it in a chant, that the average fatigue in the initial wave for people who don't have an affective disorder, that's what this is. This coefficient is saying, how are people with a history of affective disorder different from those without? And this is actually controlling for length of time with the disease and aggregate current distress. And this is saying, if you've had rheumatoid arthritis longer, do you have more or less fatigue? And this is saying the fatigue is higher, but it's not significantly higher. And this is saying For people with higher average distress across the observation period, yes, they tend to have significantly higher distress. This intercept is saying the slope for a change in distress to a change in fatigue. That's a different question, right? So up here, the 1.78 is telling me your average distress, your average fatigue. This coefficient, the 1.02, is saying for a 1 unit increase in distress between waves, the fatigue went up by 1%. So this is saying not only do you have levels, but you have change. Change in distress between waves, change in fatigue. And that's powerful. So, you know, they actually, that's going together within a person. This is within the person. And then this is saying, does that slope depend on whether or not you have a history of affective disorder? No. Does it depend upon how long you've had arthritis? No. Does it depend upon your average level of distress? Yes. For people that tend to have higher distress, you add this coefficient to this coefficient, standard interaction, solving for an equation, you actually have a weaker relationship. Why? Because you start higher. Same thing, ceiling effect. And then you have a year effect. The longer you've had arthritis, the more over time, fatigue went up, but it's not modified by whether or not you've had a history of affective disorder, how long you've had the disease, or average distress. It's just, it goes up. It doesn't depend on anything. Okay. So, now, I'm not going to make you raise your hand and say, yes, I'm going to do multi-level walls. But I do hope that now you know you have this tool. Hopefully you'll have enough information to get help or read up on it or take a class. Lisa Hoffman teaches a wonderful year-long class in psychology. Jimbo Baird in educational psychology teaches growth curves and multi-level modeling from a latent variable model perspective. And Walt Stroop in statistics teaches, he calls it mixed models, same thing, using stats in the statistics department. He does a wonderful job. So we have a lot of resources here on campus. I teach this seminar, you've had enough of me probably for the last long time. I teach it every other fall, so I'll be teaching it next fall probably if our rotation is consistent with what we've been doing before. And you can go to great 2-day, 2.5-day, and week-long workshops on multi-level modeling. And you can bring your data sets with you. It can help. At ICPSR in Michigan, there's one in Chapel Hill, and then Rodebush and Brick, the Scientific Software International webpage, they do workshops in Chicago. And you can also go to England, and they have some great workshops in Essex on mixed models and multi-level models using stats. Thanks.
Thank you all for sticking around on a Friday afternoon, and I'd be very appreciative if you get a chance to fill out an evaluation, and you can either leave them on that table out there or
And Mindy, we're going to have the handouts.
yes, everything will be available on our website, including the video. Give us a week or two to get it up and running and everything. But the PowerPoint presentation and the handout materials are actually already on our website right now. So
What's the website?
ssp.unl.
the first one on that reference list.
ssp.unl.edu. And if you don't know much about the SSP, Mindy can check out their webpage. It's a lot of great resources.